Good afternoon, everyone, and thank you for joining us today for this rules workshop. I'm Amelia Boyd, and I'm the program manager for the Commission and the organizer for this webinar. This meeting is being recorded and will be made available sometime next week. The documents which will be discussed here today are available in the handout section and on our website, which is wmc.wa.gov. All attendees are muted. Panelists may unmute themselves and share their webcam. Attendees, if you have a question, please use the raise your hand function or use the question section. I will get to your questions as quickly as possible. Please refer to the agenda in the packets for the topics to be discussed. I will begin the roll call of panelists and staff. When I call your name, please introduce yourself. So first up is Dr. Roberts. Go ahead.
I'm Alden Roberts. I'm a commission member. Background is in general surgery.
And hopefully Dr. Jager can hear me. Maybe not. Dr. Trescott?
I had to unmute. I'm Claire Trescott. I'm a family practice physician and a member of the medical commission.
Heather?
Yeah, I'm Heather Carter. I'm an assistant attorney general and I'm a legal advisor to the commission.
Mike Farrell?
Hi, I'm Michael Farrell. I'm the policy development manager for the medical commission.
And Renee?
Good afternoon. My name is Renee Fullerton. I'm Executive Director for the Board of Osteopathic Medicine and Surgery, who is also conducting rulemaking on this topic.
And Dr. Small?
Hi, I'm Bob Small. I'm a commissioner on the Medical Commission, and my background is in psychiatry.
And Stephanie?
I am Stephanie Mason. I am the legislative liaison for the Washington Medical Commission.
And then Tracy?
Hi, I'm Tracy Drake. I am the program manager for the Board of Osteopathic Medicine and Surgery.
Thank you. And Ms. Blake, you may now read the script.
Okay, thank you. I'm Christine Blake, public member of the Commission. Good afternoon. I will be the presiding officer for this rules workshop. Today is Monday, April 19th, 2021, and it is 1:04 p.m. This meeting is being held via the GoToWebinar platform and will end at approximately 3 p.m. The rule being discussed today is regarding telemedicine. The pre-proposal rules package was filed in the Washington State Register as 19-19-072 on September 17th, 2019. If there are any questions about the rule process, please input them into the questions section. We have two items on the agenda today for discussion. First, should the exemptions to licensure for following up with established patients and peer-to-peer be in this rule? Mr. Farrell, would you please address this question?
Yes, I'd be happy to. I wanted everybody to know that there is a statute, or excuse me, there's a bill that's going through the legislature that will affect this draft language. Substitute Senate Bill 5423 has passed both the House and the Senate and has gone to the desk of the governor, and it may be signed this week. But what it does is it creates a new exemption, a licensure exemption in the Medical Practice Act, and it will allow a Washington licensed physician to consult with a physician in another state who's not licensed via telemedicine, so long as the Washington licensed physician retains responsibility for the care and treatment of the patient. So in the draft rule are two exemptions. They both come from the Commission's current interpretive statement. The second exemption is now moot. That's the peer-to-peer exemption. That's the exemption that will now be in statute, provided it's signed by the governor. The second thing the bill does is it modifies an existing exemption, which currently allows any practitioner licensed in another state to treat a Washington patient, provided they don't open an office or appoint a place of meeting patients in our state. This exemption is wide open It's used by some people to justify practitioners practicing telemedicine in our state without a license. It was never intended to do that. We made that very clear. The commission made that very clear in its telemedicine guideline. But now the legislature has amended it to say it has to be in person. So it allows the in-person practice of an unlicensed practitioner, provided they don't open an office or appoint a place of meeting patients. And this affects the last criterion in the first exemption. So if that's confusing, we can take a look at it and you can see exactly what language we can now delete. Thank you.
Does anyone have any discussion around this?
So can we take a look at that as Mike suggested? Because I did find myself a little confused listening to the explanation.
I agree. I'm not sure I understand how, I understand the intent of someone coming to this state in an emergent situation such as we have had over the past year and seeing a patient. I'm not sure how that applies to telemedicine though, because that's an in-person thing.
Right, it doesn't. If you scroll down to 652, section 652, which is the draft language for licensing exemptions, you'll see it. So the first exemption deals with established patients, and that's not the one that I'm talking about. It's the second one, subsection 3 of 652. It deals with peer-to-peer consultations. This is exactly what the legislature meant to put into statute, allowing a peer-to-peer exemption by a physician outside the state of Washington in another state. Let's say the MD Anderson Cancer Center in Houston, real life example. We had this come up twice in the past 6 months, where a physician at MD Anderson refused to provide a consult to an oncologist in the state of Washington treating a patient with cancer here because we didn't have the licensing exemption, even though we have this interpretive statement. Now the legislature is putting this into statute. So this exemption, which we were proposing putting into this rule, is moot.
Yeah, and that makes sense, and that I don't think that's not where I got confused. I got confused when you said that there was a legislative action to allow someone to come in person as long as they didn't, a physician to cross into our state in person as long as they didn't establish an office.
It's an existing exemption that allows anybody to practice medicine in our state so long, if they're licensed in another state, they can practice medicine here so long as they don't open up an office.
Okay.
It was enacted in 1908. It had nothing to do with telemedicine.
Right.
It's very outdated. So the statute, the exemption was amended to require it to be in person. And this is how it comes into play in this rule. Look right above section 3. It's the established patient exemption in the draft rule, which is sub 2. You are proposing, at least in this draft, that somebody providing follow-up care to an established patient is exempt, provided they meet 3 criteria. And the last criteria, sub C, says the physician does not set up an office or place of meeting patients in Washington. That was put in there to meet the statutory requirement. That is no longer needed in this rule.
Got it. I understand.
Because it has to be in person.
So while we're looking at sub 2 though, and maybe I'm misreading it, the way that reads to me, the out-of-state physician could continue to provide care to an in-state person on an indefinite basis without getting licensed in the state of Washington. And if I'm reading that correctly, I just said, is that what we want? That, that could theoretically go on for years without the physician being licensed in Washington. And obviously I have some misgivings about that. I think there ought to be some sort of time frame on that, but that's just my personal opinion.
So I'm less concerned about that. And the reason is, I think part of the reason why I'm less concerned is I live on the border between Oregon and Washington. And there are any number of patients who seek their medical care in Oregon, but will need on an extended care basis the ability to conduct telemedicine visits with their physicians. And somehow or other that needs to be accommodated. I think if you've seen somebody at the Mayo Clinic, you probably need to be able to continue to consult with that person long after they have seen you the last time, because it's ongoing with a problem which is unique that they need to be able to manage. And I think there are any number of circumstances where, in fact, that it works well, and the requirement of an in-person establishment, I think, is not an unreasonable requirement based on how I see things. The problem that I actually have, and I'm not sure how to address this issue, I want to make it so this is possible, but when what we care about is whether somebody is practicing good medicine or not. And if somebody that doesn't have a license in this state is practicing bad medicine, what do we do about it?
Well, Alden, they are licensed in another state, and so we report them to the board of their state. Working in a large organization that exists across state boundaries and has physicians licensed in multiple states, I see this a direction we're going where we have more fluid boundaries. And anyone under this is licensed somewhere, and we have some ability to communicate with wherever their licensure is. So I'm not too worried about this myself.
Well, I would agree with you, Claire. I just think that I see in the future that we're going to get complaints from Washington patients about a physician who lives in some state with which we don't have, that they're not licensed in our state. And I think that going through other states' boards and commissions is probably not an unreasonable thing. I just would like to sort of remind folks that across the country, there are very few boards which do things similarly. So we all practice in different ways. And, if somebody complains about a patient who is, for example, gone astray with our opioid rules, and that's not astray with the opioid rules of Texas, what do we do about that? And it may be that the answer is nothing, because Claire, you may absolutely be correct. I just want to make sure we think about it and make a decision based on information, not just letting it, don't make a decision because we didn't make a decision.
Yeah, I think you're right, Alan. I'm curious too, Mike, maybe you know this, are other states, is there a reciprocity here? Do other states, have they addressed this in a similar way, or have they addressed it at all?
Yeah, I took a look at a lot of other states to see what their exemptions are, and it's all over the board. Some states, well, first of all, your current interpretive statement provides for this, but adds the criterion that the follow-up be infrequent or episodic, without defining those terms. So that's an option for this rule. You could say infrequent or episodic. We took it out of this so you could have a discussion on what kind of parameters, if any, you wanted to put on. Other states sometimes limit the amount of interaction. Wyoming, for example, it's something like 12 times within 1 year. That's the most specific state exemption that I found. Some are vague, saying infrequent or episodic. It just runs the gamut. Those are the two I can think of right off the top of my head.
Yeah, I'll just add, just because I had a case in Minnesota. So Minnesota specifies more than 10 times in a year.
Well, do you guys feel that it's more reassuring to have it episodic?
I personally don't. I just think there are too many people that live in border areas in particular where telemedicine may be the best mechanism for them to be taken care of. And to say that you can't, that you have to get in traffic and drive across the river to Portland to see somebody when, you know, you don't need to go see them at all. You can manage it by a telemedicine consult. I don't like that idea very well. And it's a service issue, not a quality of care issue. And so that's why it's a little bit odd for us, because what we're interested in is having good service rather than in regulating medicine in this case. And I'm not sure that we get much out of a license other than being able to actively engage in a investigation and potential disciplinary action, which, as Claire said, we could delegate to another state's board.
I can see where this would be useful for large organizations that have hospitals, for instance, like Peace Health in 3 different states, Oregon,
Yeah.
Alaska, and Washington. And unfortunately, we'd have to have our providers licensed in Alaska to do that, to do the telemedicine when they really live in Washington. And it's become a little bit of a hassle all around because they don't want to pay all those extra fees for all this licensure. And it's so remote in Alaska, you know, the last frontier, that it would really be of benefit. But I can also see what you're saying, Alden, that maybe just pushing it off to another state wouldn't be the best way to follow up on it. But I see both sides. I can see the really good benefits, and then reporting it to their state board if there's a problem. But those are just my thoughts.
I want to make clear that my personal opinion is I think this should go the way it's worded, which means that if you've seen the patient, you've established a relationship, that telemedicine is a legitimate mechanism for continuing that relationship, even though you're not in the state. That's my position. And I want to make sure, I want to see if we can make sure that we have addressed the disciplinary action issue in order to achieve that goal. Now, Bob had an objection. I'd like to hear more detail about your objection, because I think you have, I can see where your position is valid.
I would say my objection was very soft, and I just wanted to raise that issue. Particularly around the border issues, I think you've got a really good point about that. And it's not just Washington, Oregon, it's also Washington, Idaho. And in my other work, even though Canada's in between, we actually look at Alaska and Washington as bordering each other in terms of providing medical care.
And there are areas that people go for specialty care, as I mentioned, in Mayo, but any of a variety of places where they come back here and need to have the ability to have telemedicine consults, basically.
So we do have one. Sorry, go ahead, Mike.
Oh, I just wanted to point out that this is real world stuff. I received a phone call from a psychiatrist in California who had a long-term relationship with a patient, called me up and said, my patient has moved to Washington. It may take her a while to find another provider. Can I provide telephone therapy to her, and for how long? And that was a hard question to answer.
Well, I have a friend that lives in Portland, and this is the reverse of what we're talking about. That person just moved to Washington, and they can now have a visit at Seattle, a video visit at Seattle Children's, whereas when they lived in Portland, they couldn't. And what that means is the closer you get to Children's, the more likely you are to be able to have a video visit. And that doesn't make any sense at all.
So we do have one hand raised, and I will go ahead and unmute Sharon if you would like to go ahead. Maybe not. Oh, we have another. Greg, if you would like to go ahead.
This is Sharon. Can you hear
Oh,
me?
there's Sharon. Yes.
I don't understand, why can't we just put in this rules that anyone who gives telemedicine to anyone in the state of Washington is subjected to our rules and regulations and our medical commission? We may not be able to do something in another state, but if they don't follow that, we can then say to our commission, they cannot provide those services in our state.
I had a lot of difficulty hearing that.
Why we can't put in our medical commission that anyone providing telemedicine services must abide by our commission, and if not, then they wouldn't be able to provide that service to our state.
So I think, did you hear that time, Dr. Roberts? Oh, I think you're muted.
Not really. It sounds like what is being suggested is that people have to agree to abide by our rules and regulations. I'm not sure how we would get such an agreement, nor am I sure how we would enforce it.
I think that's what she was trying to ask as well. We do have another hand raised. Greg Kling, if you would like to go ahead.
Oh, I got on this a little bit late, so I just wanted to make sure I understood what, where this is at. And I'm in Nashville. I'm in Nashville, Tennessee. I'm licensed in 28 states. I work for MD Live. And so I guess, I'm reading what I have in front of me here, and then I just want to make sure nothing's really changed, for out-of-state docs providing care for, large, nationwide networks like Teladoc, Amwell, us at MD Live. And that was kind of my, the reason I jumped on this was to see if any way that was going to be changed. And I mean, it sounds to me like you're talking about if you have an established place. Obviously, when we're doing virtual urgent care, we're establishing at that time, there's no guaranteed follow-up. So my interest is trying to find out, is that going to be changed somehow as a result of these meetings that you're having? Does that make sense?
Yes.
So
I don't.
You currently have licenses. You currently have licenses in lots of different states.
Yeah, 28 states.
Right. And so I think what we're talking about is how do we manage, what we're talking about in this particular section is how do we manage people who are licensed in one state but not licensed in ours. And I think
okay.
what we're sort of getting at is, no, if you have a license in our state, you're practicing medicine in our state, and we recognize that, whether it's telemedicine or some other sort of medicine. By the way, I'm giving you an opinion, and so I'm happy to let one of the attorneys jump in at some point too. But I think what we're trying to do here is to facilitate the practice of medicine, and that happens to include telemedicine. And if you have what we're trying to manage is to make it easier for people with established patients to manage those patients.
Gotcha. Okay. Like I said, yeah, I came in late, so I just, I was just reading some of this here, and I just wanted to see if it was going to affect how it's influences what I do. So, not in a selfish way. I was just kind of trying to understand it. So.
Thank you. Okay, so there are no other hands raised. Is there any more discussion about this item? Go ahead.
I have one consideration, and that is I got a call from an attorney in another state who said this exemption, which is currently in your interpretive statement, says a physician can practice via telemedicine with an established patient. But what if they're using something that doesn't constitute telemedicine? Then they can't do it. So I just want to throw this out. I'm not recommending it, but one consideration is to take this exemption and put it in its own separate rule so that it applies to all physicians, all treatment modalities for established patients, rather than just being within the confines of telemedicine. So that,
unless we're talking about definition of telemedicine, I'm not sure I understand his question.
okay,
I think you're trying to make the definition be broad.
The definition, as I see it, is the definition that is currently in our draft rule is so broad that it probably covers every type of interaction a remote interaction a physician will have with a patient. So I'm not sure there's any other type of interaction that would apply.
I'm not anxious to take that and put it somewhere else. I sort of like what we're talking about.
Okay.
So while we're looking at the definition, and I'm just asking a question here. I don't have an opinion, but are we going to run into some difficulties with what exactly are telecommunications technologies?
You know, I think at some point or another, we're likely to, I don't think there's a perfect definition. And I think what we've done with this definition is to make it as broad as we can to try and welcome legitimate practice of medicine. And frankly, I don't care about defining the term. I just want to be able to say if we see the practice of medicine in a fashion which is below standard of care, that can be taken care of, whether it's referring it to another state to manage it or managing it in our own state. So I'm not sure how to make this better, because I think anything we put into a rule is likely to change as new mechanisms come out.
And again, I'm not necessarily objecting. I just wanted to raise that question.
I like this definition precisely because it tries to allow for new technological advances or new ways that we practice. Like a year ago, nobody did telemedicine, and now everybody does. That's an exaggeration.
I realize that.
So we do have one more hand raised. Marlene, if you'd like to go ahead.
Hi, my name is Marlene Converse, and I work for Kaiser Permanente. On the topic of the definition of telemedicine, we appreciate the definition being generic enough that it will allow for future technologies that could be practiced, rather than writing something into a regulation that would limit our ability to be flexible as technology advances. We don't want to be back in doing rulemaking again if we have a broad definition that will work now and into the future. Thank you.
Thank you. Okay, that's the last
Any more,
one.
Amelia?
Nope, that is it. So we can move on to the next item.
Okay, the second question, what are the circumstances in which the standard of care may not require an interview or examination of a patient?
So this is something we need to decide whether we want to put the circumstances in rule.
Mike, you had an explanation of what this might mean that was very helpful to me. Would you mind talking about that for a minute?
Yes. I looked at a lot of rules across the country, and the one I was most influenced by were the telemedicine rules established by the Medical Board of Iowa. And so some of this language throughout this rule comes from that. And this section comes directly from the Iowa rule. So these are instances in which a physical exam or personal interview would not be necessary. I had not even thought of this, but I put it in for your consideration. Note that the introductory sentence says,
I'm sorry, Mike, can you just say where you are in the draft rule here?
Yeah, I'm at 667. It's near the end, Bob. Section 667.
I will find that. Go ahead, please.
I have a reservation about this because the rule says it applies whether or not the physician is using telemedicine. So it is a rule within a section within a rule. It says this applies to any practice. So that it gives me a little bit of discomfort to have a section in a rule that says it applies outside the rule.
The other thing, I think the other thing that, well, what caught my attention most significantly is when is a personal interview not necessary? So you have neither a physical exam nor a personal interview necessary. And I think that you had mentioned that that relates to interactive forms, for want of a better word. And I actually have some concerns about that. So could you elaborate on that a little bit, Mike?
Yeah, I was mixing up two concepts when I was talking to you, Alden, about that. The interactive form issue is in a different section here and relates to one of the letters that's in the packet.
Okay, sorry about that.
That was my miscommunication.
I am not quite certain. Then I'll rephrase it. I'm not certain when a personal interview, when you're talking about prescribing a medication or you're talking about doing whatever, what are we talking about here? When do you neither need to see nor talk to a patient?
Mike, they're all outlined there, aren't they, in that section that you put for?
Yeah, yes, they are.
Yeah.
I didn't have a problem with any of them. I have a concern about whether this even belongs in the rule. I wanted to put it there because here Iowa is trying to tell its physicians, hey, here, try to provide guidance within a rule that these are situations in which you don't need to talk to the patient. You really need, I think you need to look at this alongside two other sections of the draft rule, which talk about the need for taking a history and doing a physical exam of the patient before you see the patient, treat the patient via telemedicine. I didn't want to make this too complicated, but I think you need to look at that in addition to this to see the context and whether you really need this at all.
I see. Okay, I'm going to default to my sort of normal position of if you're not practicing good. What you have listed here is just how we practice medicine. And I would default to, if it's not good medicine, it ought to be addressed. If it is, it ought not to be addressed. And I look at this and think, this is how we practice medicine and doesn't really need to be in this rule set, but I leave it open to others.
I was thinking exactly what you just verbalized, Alden. I mean, as I look at this, most of these are things I did when I was in practice, regardless, and there was no telemedicine back in those days. seems to me that these are standard of care issues rather than unique to telemedicine.
Agreed.
This is April. Can you guys hear me?
Yes.
Yes.
Perfect. Anyway, I just was gonna sort of echo what I think Mike was sort of getting to is I worry a little bit when you get into the idea of giving situations wherein you might not have to have an exam or a specific interview, that then people feel limited by that unnecessarily. I think, again, as Dr. Small and Roberts were saying, the job of the commission and the overall is to sort of ensure that there's good practice of medicine. And I think we can decide that on a case by case basis to an extent. I think if we in the rule try to define exactly what that is, we're going to get into something that requires too much detail and cause trouble without meaning to.
Well said, April.
So we do have one hand up in the attendees list if you want to go ahead and take that. Jeb, go ahead.
Hey, thanks, Amelia. And, good afternoon, everyone. This is Jeb Shepard from the Washington State Medical Association. I guess first, a quick question. Will there be an opportunity on the agenda to talk more broadly about the rule? Because this particular issue feeds into a lot of our current thinking on this, in that a lot of what's included in the draft is already being practiced or is already governed by a state or federal law elsewhere, and we'd like to see it winnowed down to focus on the pieces that need to be regulated. And if there's an opportunity, I can expand on that later. But this is a good example of something that really is very prescriptive, is being practiced right now and doesn't necessarily need to be regulated or placed in a rule.
So there may be time at the end once we get through all of the agenda items, but if you have a comment about this particular section, feel free.
I don't believe it belongs in a rulemaking along with the vast majority of the rest of the provisions in the rulemaking. And so I just wanted to use this opportunity to ask if there would be an opportunity to speak more broadly about the rulemaking, because this is a really good example of our concerns.
So are there any other comments about this section? Do you want to strike it from the rule? Is that what I'm hearing?
Yeah.
So the whole section, right? Yes, okay. Was there any other related sections that you need to talk about? Mike, you had mentioned looking at this alongside some of the others.
Yeah, how to establish the physician-patient relationship and whether to, what kind of parameters, if any, to put around taking a history and physical. That's a big one. We can certainly tackle it or go to the comments. I mean, the submissions.
I have a question for our attorneys, and that is how easy is it to determine whether or not a physician has established a physician-patient relationship in the practice as it currently exists? Because I think that's a difficult problem now, and I'm not sure that it's necessarily different in person or by telemedicine. I'm not sure. I think that's how we practice now, and I think it's sometimes not clear, and I'm not sure how to make it clear. Is Heather on?
Yeah, I'm here. So I think you're right that sometimes it is hard to when you get a case to show exactly where the patient physician relationship was established, especially in a hospital, like when did you take control of the patient's care? And I think that if it's something you think doesn't need to be in rule, you could take out. This one's pretty short. It just says when it's required, you need to do it in a physical personal encounter, and when it's not, you don't. So it's really just leaving it up to discretion of the doctor. I don't know if that answered your question though, but I agree, it is sometimes difficult to figure out where and when it was established in general.
Yeah, that actually is that's exactly what I wanted to know. But after a fashion, I'm not sure why we should try and develop a rule related to what a physician-patient relationship is as it relates to telemedicine any more than we do in regular practice.
If you're referring to 656 there on the screen, one of the big issues after you adopted your guideline, we would get calls asking, can you establish the physician-patient relationship via telemedicine? Can you do that? And the old way of thinking 10 to 15 years ago was, by many states, was that you had to have a physical, an in-person visit prior to having any telemedicine visits. And that notion has kind of gone away. And most states now are allowing physicians to establish the physician-patient relationship via telemedicine. So the first instance is a telemedicine visit. So that's the key to this section, that you can establish this relationship via telemedicine. You don't have to see the patient in person first.
Okay, I understand that. That requires a rule, a WAC?
Well, I think it requires a very clear statement from the commission to the practitioner community about what your position on that is. There's a very vague statement in your telemedicine guideline about that. It's just not very clear at all, even though that's what you meant to say. So I think making a clear statement in some way would be beneficial.
Okay, that's fine.
We do have one hand raised. So David Streeter, if you'd like to go ahead.
Hi, this is David Streeter with the Washington State Hospital Association. I just have a clarifying question about this rule and how it relates to the rule that we previously discussed. So 656, you're establishing what a physician-patient relationship is. 652, you're allowing existing relationships among out-of-state providers and in-state patients. And I guess what I'm wondering, is this criteria meant to apply up in 652, or are you envisioning something different? Because right now it's a little hard to tell where if this applies in that section and up in 652.
Okay, if I understand your question right, 652 allows a non-Washington licensed physician to treat a patient in the state of Washington, provided they have a prior established relationship. 652 doesn't say how that relationship is established. It just requires that the patient was located in the same state as the physician, where the physician is licensed. So if they're located in the same state and they have a physician-patient relationship, no matter how it arose, and that patient goes to Washington, then that physician in another state can provide follow-up care.
Mike, it also applies to a licensed physician, a physician who is not licensed in Washington. Whereas the other section is someone we're presuming who is licensed in Washington.
Right. So I don't think it's the commission's business to say how a physician-patient relationship is established in another state. That's up to the other state. But it is the commission's business, or maybe the commission's business, to say how it's established in Washington. David, did that address it at all?
Does I guess so. It sounds like you're not interested in tackling what the established relationship would be in the other state, and you're debating right now whether or not you should establish criteria for Washington State. I guess that, I don't know, my confusion was just that you had established relationship in two different WACs, or two different proposed WACs, and one criteria in 656 it appears to apply in this state, whereas 652 was really silent on how that relationship is established. And so that's what my question was: is there meant to be a distinction between those two sections when it comes to the criteria for an established relationship?
Interesting question. Well, I guess one of them is determining whether or not a relationship has been established in this state. We certainly can't determine what other states consider a relationship, but we can determine whether or not, I don't know, I'm not anxious to make it difficult. I think that's the issue, is how do we facilitate this? And the question is a good one, but I also hope that in trying to solve the answer to this problem, we don't make things too hard.
Can I?
Go ahead.
I think that's a real good question. I have to do some thinking about that to try to reconcile those two sections. I have a suggestion. This comes from the Iowa rule. I'm not sure why it didn't make it over to this draft, but we state in 656, there are two ways to establish the physician-patient relationship, and one is by in-person medical interview and physical exam. The other is via telemedicine, but there's a third option that I want you to consider, and that is the peer-to-peer consult. So it's a physician in another state providing a telemedicine service to a physician treating a patient in our state. And that physician in the other state may not have any direct contact, remote or otherwise, with the patient, but may just have contact with the treating physician in our state. So the third way would read consultation with another practitioner who has an established relationship with the patient and is responsible for the diagnosis and treatment of the patient. This mirrors, in a sense, the new statute, or the bill rather.
Could you repeat that one more time, please, so I can put it on the screen?
Yeah, so it'd be C or B.
C.
Consultation with another practitioner who has an established relationship with the patient and is responsible for the diagnosis and treatment of the patient.
Thank you.
Amelia, I have a question.
Sure.
So, Mike, remember the issue that came up, I don't know, several months ago regarding the patient who did not have a physician who was going to consult with other physicians out of state, but wanted to consult with the physicians out of state directly?
Yep, I do.
And they wanted to do it via telemedicine.
Right.
Where would that fit in this?
It would
not
be
telemedicine?
It would not be allowed.
So we wouldn't be able to help that person still.
That's right. The exemption that the legislature passed and deals strictly with physician-to-physician consultation, not an out-of-state physician treating a Washington patient via telemedicine. The only way to do that would be if they're already an established patient.
Okay. But if they're doing a consult, whether they're looking at patient records that a physician sent them, or they're looking at patient records that a patient sent them, they're still looking at the same records.
Yes, but the dividing line is that the physician outside of the state of Washington is communicating their findings directly to the physician in the state of Washington.
What's missing, Melanie, is that you need somebody who is responsible for that patient care in this state.
I get that, but again, we had a desperate plea for help from a person that didn't have a attending physician, or that wasn't willing, the physician that she had been working with in the past, for some reason wasn't willing to consult with an out-of-state physician. I don't know, it's kind of a strange set of circumstances, but in that case, even this would not help that person. I just wanted to make sure that I understood that correctly.
Correct.
Okay.
So I want to make a couple comments about this up on the screen. My first one may seem a little nitpicky, but in sub A, as a psychiatrist, I did not do a physical examination on every patient that I established a relationship with. So I might delete the word physical and just have examination in there, since there's more than one type of examination.
I agree.
Or I'm open to other, or, if anyone has other suggestions, but my other, go ahead, Alden.
Just a quick question. Does it need the word interview? I mean, it seems to me as though it could be, you could just say examination. I don't know if that would.
I think saying medical examination implies that.
Yeah, or history or whatever. Yeah, a medical examination, maybe.
Yeah, it's already in there, the word.
Yeah, I think that would work.
Should we be using the word physician as opposed to physician or physician assistant or provider or something?
So
right?
So WAC 246919 is the physician WAC. So we use physician here, and then the physician assistant rules will mirror this, except it will say physician assistant.
Okay, thank you.
And my other comment was, so with the sub C that's added there, I'm a little confused about exactly what that means. It could mean that if I consult with another physician, I don't see the patient, I just provide some consultative input that I've established the physician-patient relationship with that patient. I don't think that's the intent, but again, the way it's worded seems confusing to me.
That could actually, I'm not sure I understand the entire context of this, but that could actually be a major problem if you have somebody who gets kind of a hallway consult, so to speak.
Right.
So.
Agreed.
And from the emergency room standpoint, I pretty regularly give advice over the phone to a provider who's interacting with another patient that I can't see and have limited information about, which is a form of telemedicine, I suppose. I have a bit of concern about this requirement to have a valid physician-patient relationship, and that we're defining how to establish it. It's not a bad concept, but telemedicine is something that is done on a pretty regular basis without what most of us would consider to be a standard physician-patient relationship. So it's not that I think it's a bad concept in certain contexts, but in other contexts, it doesn't make any sense. It's another spot of this rule that made me question whether or not we were attempting to be too detailed.
What if instead we just said a physician who uses telemedicine must establish a valid patient-physician relationship and just left all the rest of it out?
I mean, I suppose it just depends on what you mean by that, right? If I'm talking on the phone to you, you know, Alden, and we're across the state from each other, and you were asking me advice about the management of a pediatric surgery patient, did I just create a physician-patient relationship? I would argue that I didn't. I have a relationship with you, but I'm just giving general advice on the information provided.
I would take that back inpatient. Let's say what we have now. If you give me a call and say, hey, I've got this person who has left lower quadrant pain or right lower quadrant pain, and they have an ovarian cyst, and I'm pretty sure it's just an ovarian cyst, they don't have a fever, can I just send this person home and let them follow up with you in the office next week? That's the same thing. And that already exists. So what I'm sort of hoping for, if we just say establish, you know, I have a friend who got in trouble because an OB person called and said, I've got a person that has a low-grade fever and they're pregnant. And she said, well, just get the, you know, get blood cultures and whatever. And she got dragged into a lawsuit because that was a physician-patient relationship because it got put in the chart. And I think those are the sorts of things that we want to avoid. We do hallway consults now. We do, you know, I would call a friend of mine at Emmanuel and say, I've got a trauma patient. What are we going to do with this? You know, there are any of a variety of different reasons why we currently in current practice talk to other physicians. And that's one of the, I think, April, you're right. This is why we've got to be careful about defining a physician-patient relationship. And I kind of like just saying a physician who uses telemedicine must establish a valid physician-patient relationship and just leave it at that. Because we kind of do that with regular medical practice.
If
Mike?
Are we trying to say that the person has not established a valid patient relationship, therefore has not assumed the responsibility for the care? I mean, I think in a way, don't we want to shield the hallway consult and make it a safer place to give advice? So I think I'm not sure that wording does it, Alden.
I'm open to
we should be more clear.
Do we want to, I'm sorry, go ahead, Mike.
I believe the only issue, this was, and I agree, this is confusing language and potentially problematic. The only issue the question this was designed to answer is, do I need to see the patient in person before I see the patient via telemedicine? So the answer to that is probably no. I mean, that was the old way of thinking. That's probably no. And it may be answered in the very next section, because then we get into the details about what you have to do. So maybe talking about establishing the physician-patient relationship is not a very useful way to frame it.
Well,
yeah, sorry, Alden. Chris, go ahead.
You say you keep getting questions about, you know, what is it? Claire had an interesting thought, which is something on the order of responsible for the diagnosis and treatment of the patient. That is sort of the responsibility is the issue that we're trying to get at. If you don't have the responsibility for the treatment of the patient, it's not a patient-physician relationship for the diagnosis and treatment.
You can't see me, but I've been shaking my head over the hallway consult and trying to make sure that we have some language in there that protects that, because that is a problem in a lot of facilities. So if we could put something that would curb that, so to speak, or not have it be that kind of a consult and protect a provider, that would be great to have in there.
Yeah,
Especially if we're going to, if we're not accepting license to let, from state to state. Go ahead, Dr. Small.
No, it's like I was going where you are, April, and that maybe we need, and this is not necessarily the right wording, but some kind of language that physician-to-physician consultation is not the practice of telemedicine. I think you're on mute, Alden.
Yeah, the only reason for not saying it that way is that might have reimbursement potentials. Although it's currently not reimbursed now, that doesn't mean it won't be in the future.
I think we want to say that ultimately the responsibility for the patient care belongs with the physician who has established a relationship with the patient. In other words, who has seen them enough that they are the treating clinician.
I think turning it around perhaps and saying if you have responsibility for the patient care of the patient, that is a physician-patient relationship.
Right. So I think in effect it is. It's hard to understand, Mike, you might know this, how that something like that would fit into this part of the document, though. What we're trying to say here.
Well, I'm tending to think that the less you say, the better. And because this is a very tricky issue that you're getting into, and I don't know if we really need to address it. I'm sorry I put this language in. I was just trying to answer the question, which we get, do I need to see the patient in person before I see the patient virtually? And I think the answer is no, and I think it might be answered in 657 about what has to happen. What does a physician have to do before that physician sees a patient via telemedicine?
Well, again, I think to Jeb's point, less is better. And I would move that we delete this section.
Prior section 656, this one?
Well, yes, the section that we were talking about.
Okay.
I think trying to define a physician-patient relationship differently from how it is defined in the practice of medicine elsewhere is a mistake. And I think this is a form, telemedicine is a form of practicing medicine, and it should be defined, that practice should be similar.
So is that how you all the panel feels? Delete this section?
I agree.
I would agree with that.
So we do have one hand up. David Streeter would like to speak again. Hold, please. Go ahead, David.
Hi, everyone. David Streeter again from Washington State Hospital Association. I guess my comment is kind of moot right now, but I was also going to flag that House Bill 1196, which is the audio-only telemedicine bill, has a definition of established patient relationship that takes effect in 2023. Since you've gotten rid of the section, it may not be relevant to the conversation anymore.
Okay.
So,
yes.
While we're looking at 657, I just want to point out that has that term physical examination there in several places that I raised an issue about before.
So you wanted this change to just examination, right?
I think
Appropriate examination.
I think that's good, appropriate examination.
You know, I looked at this and was thinking, is this going to set up at least where I work, a new rule that you have to bring the patient in and do a physical exam, even though we have detailed medical records and exams that encompass all their medical care for their entire life, you know. And this is an unnecessary exam to do the piece of work you're doing. Are we going to add unnecessary fluff to what systems have to do as far as care goes? I'm just, in some systems, integrated systems, you're treating a patient that you in many ways know, and you're representing an entire staff. And now we're going to higher and higher percentages of the care being virtual.
Actually, Claire, I think you're right. I think actually, if we want to look at this as this is just another technique for practicing medicine, why can't this just say you need to provide an appropriate history or physical and/or physical, and have it so that it's open-ended, so that if if your partner did a physical on somebody the other day and they just wanted you to talk to this person because you're on call, that's not included in this. But it seems to me as though there's more here than there needs to be here by kind of a lot.
Yeah, I think, Claire, you raised a really interesting point, and it caused me to think of some cases I've had where, patient is seen in a system, and every time the patient comes in, sees a different physician, but the system, quote unquote, knows that patient well.
Right. That's very common, and more common. In primary care, in some practices, we have 65% of the care is virtual. That's a lot of the workday is virtual medicine, and that involves telemedicine. And you don't know all those patients. Some are just patients that are seen by your partners. So I think we need to at least reflect that and not and certainly not add extra work to where, oh no, this person has to come in for a physical before I can be managing their acne or whatever, So I might just be adding more chaos here, Mike, but.
No, I think the goal is to reduce the chaos, and that's what you're doing. And as I read through this, it just seems to me as though what we ought to say is, there's a line in here that says, a physician who including, prior to providing treatment, including prescriptions electronically or otherwise, a physician who uses telemedicine shall, and it goes on. But the key is electronically or otherwise, we don't care. You've got to practice. What we're wanting is the practice of good medicine. And I think we're going astray when we're trying to define that differently with telemedicine than we are with medicine, which is not telemedicine. And so I think putting these sorts of things in complicates it and makes it more likely that we're going to run into problems.
I agree.
And I think I would just say, as with physicians who practice, prior to providing treatment, including prescriptions, the practice of telemedicine shall be conducted in a fashion similar to the practice of in-person medicine, or something like that.
So you're wanting to keep this first sentence?
Oh,
Then
no.
you don't really need a rule if you're just saying telemedicine is included in the standard of care. It's just the way you're presenting it.
Yeah, that's what I'm trying to get at, Melanie. Thank you.
I think that's what Jeb said.
So we do
I
have
would
one
note for
hand
the,
up, or, oh, sorry.
You
oh,
just
I was
need
just
to
going to
know the
say,
patient well enough for the level of care you're providing.
Well, but I think that's true whether you're doing it by telemedicine or doing it in person. And I think that what Melanie just said, what Jeb was trying to say, this is a rule that we don't need to have. The goal is good medicine. And if you're not practicing good medicine, I don't care whether you're doing it by telemedicine or by in person, it's still not good medicine and you have to be dealt with.
So are you saying we need to change this section or possibly not do rulemaking on this subject?
Well, the one thing that's come up that, and Mike, please correct me if I'm wrong, is that it's usually from out-of-state people we get, what does telemedicine in Washington entail? It's not so much from Washington physicians that we get the question. So, and Mike, I need something to tell them what it means to be a telemedicine person in the state of Washington. I mean, is it always just going to be you need to have a license where the patient is located unless you're doing peer-to-peer consultations, which is now in the Medical Practice Act? If so, then we don't need a rule. But if we need to clarify that for like Teledoc and all of those groups, then maybe the rule needs to revolve around that. I don't know.
it seems like I mean, in general, if you are providing care in Washington state, I mean, for Washington state patients that you would typically want to have a Washington license, though that's actually an interesting question otherwise. But regardless, I think I tend to agree with Dr. Roberts that when there are practice issues where people are not practicing good medicine, that I'm not sure we could easily define exactly all of the different instances where telemedicine would vary substantially from the regular practice of medicine. I think if we tried to do that, we're going to end up chasing our tails a bit. And with regards to the, oh, you were just saying it, Melanie. I'm sorry, I'm forgetting it while I'm talking, but the consultation of physicians regarding a patient that they're not directly involved with, I think, is a separate situation, as you alluded to.
And Amelia, I'm not saying we don't need to do rulemaking. The rulemaking we need to do, among other things, includes if you are in Oregon and you're taking care of a patient that lives in Washington, you need to be able to do that. Or if you're in Idaho, or if you're whatever. And so there's certain rules that we need to have. But the practice of medicine is the practice of medicine. And I think what April just said is, let's not try and define the difference between telemedicine and regular medicine, because I think that's going to be difficult, or I think that's going to be non-productive.
So we also have, let me unpause my screen. We've had this policy statement on telemedicine and continuity of care for a while. Does that not cover, Mike, the out-of-state?
It does. It covers it. I would rather have it in rule that for physicians out of state treating established patients. We've also had cases, physicians in the state of Washington providing very poor telemedicine to patients in the state of Washington. We're not talking just about out of state physicians.
Sure.
And you have a provision 653 in the draft rule, which says the commission will hold a physician who uses telemedicine at the same standards of care and professional ethics as a physician using traditional in-person care with a patient.
Mm-hmm.
Does that sum it up, Dr. Roberts?
Yeah, that's what we want.
Okay. The section that you're having difficulty with, the very last sentence is a big issue that I'd love to get your feedback on. And that is that we've had a number of physicians who will make a diagnosis and institute treatment merely by reading an online questionnaire. Now, this goes back a number of years. These questionnaires, as I understand it, have become much more sophisticated. They've become adaptive and interactive. And so the issue is, can a physician use telemedicine to treat a patient in our state without having any direct interaction with that patient, but by just reading the responses to an interactive questionnaire?
So I think, Mike, it would be challenging to sort of say that that's always a no, right? Because these questionnaires and how people are obtaining information is only going to evolve and get more and more sophisticated. And I don't think we can predict that. I think leaving this, you know, if you're leaving this section into a rule, then I would say that a physician can be practicing telemedicine and will need to acquire history and perform an examination as is clinically indicated, right? And I would leave it very broad like that, because sometimes, you know, if one of us went into telemedicine and you had this really amazing, thorough history, et cetera, and you could exchange back and forth a conversation to clarify a few points with a patient, and they've given you a photograph of a rash and have answered all the appropriate questions, I don't know that I need more than that. Now, does a photograph of a rash constitute an exam? Probably not. But is that enough information for me to prescribe something like a topical cream? Sure, I think that's reasonable. But anyway, point being is that I think leaving the amount of history and examination, whether or not that's clinically indicated, should be up to the practitioner. And if they end up doing something like a bad questionnaire and are prescribing and treating inappropriately, that's bad medicine, and that would be something that we could take a look at on a case-by-case basis, I think is reasonable. If that sounds reasonable to everybody else, but.
I would
really agree.
Go ahead, Claire.
I totally agree. We're getting into specifics about an evolving area of medicine. And these are getting better and better. By the way, we do photographs of rashes and of things all the time now. In primary care, you have patients sending pictures of things that are from their body all the time now. I mean, it's just gotten more and more prevalent. And I remember a decade ago arguing about with dermatologists about could we ever have photographs of rashes, and now the initial consult on most patients go to a dermatologist, and there's a record of the rash in the chart now with that photograph. And it's much more sophisticated than it was initially. I think if we get into this area of internet questionnaires, there's a whole science around that, and preventative care that's been evolving in nurse care coordination. So I'm worried about us getting into too much specifics on any of these areas that are quickly evolving. So and that was a long way to say I agree with you.
I was just going to comment that I don't think this is unique to telemedicine. I think this is going on more and more without telemedicine. I mean, you could be a dermatologist in state, and somebody sends you a really great picture and you say, come on in and I'm going to leave this prescription for you. So, I think this is more an issue of the general practice of medicine rather than specific to telemedicine.
On the one hand, I recognize that there are specific interactive forms which are being used to take the place of any sort of an exam and could potentially be used on an ongoing basis. However, I also think that that's probably bad medicine, and that's going to be that's going to show up as bad medicine and will be managed. And I don't think a rule is going to stop that from happening necessarily either. So, the question is, would it help us in terms of a disciplinary action? And I think the answer is probably not any more than it would if this was somebody who didn't see in person and wrote a prescription for.
I can come up with some language based on Dr. Jager's comments and everyone else's comments to make this real simple, maybe a sentence or two about judgment and acquiring a history and physical when clinically indicated.
So we do have one comment in the question section, and then we do have one person with their hand raised. I'll read this comment real quick because it's relevant to your discussion right now. It says, sounds like a computer algorithm with appropriate examination would be good medicine if it came up with the right diagnosis. We are leaving it open for not needing an advanced degree to practice medicine. So that's the comment. Does anyone have any comments about that?
Well, it's possible to practice bad medicine with a license as well as without a license. And I think it's capable. It's possible to have bad outcomes and good outcomes based on luck. But basically, that's true no matter how medicine is practiced. And although I wish it weren't, I wish we had a better mechanism for governing things. Right now, we don't have a way to take somebody out of practice who is a serial killer until we find out that they're a serial killer.
So we do have one
I
hand
don't know how
raised.
we got there, Alden, but could you read the last sentences of that comment, Amelia?
Oh, it said, we are leaving it open for not needing an advanced degree to practice medicine.
My reaction to that is, regardless of how good the computer algorithm is, a physician has to make the final judgment about what to do with that. So it really is the responsibility of the physician to exercise good judgment regarding what's in the computerized algorithm.
All right. So I will try and get this one hand. Nicholas, if you would like to go ahead.
Thank you. Nick Shilligo with 1-800-CONTACTS. Appreciate the opportunity to speak on this section. Actually, most of my concerns were already addressed around the questionnaire language and the physical exam language that you guys seem to be moving away from, and greatly appreciate the discussion and willingness to do that. The only thing I have remaining in this section is that the interview language that was removed previously remains in this section, and for consistency's sake, I think it would clean up nicely to remove that.
Oh.
Third line down there from the top.
Right.
Maybe just say collect the relevant medical.
Okay, anything else? Oh, we have one other hand up. John? Maybe not.
Right.
Go ahead, Mike.
I just want to make clear on what the wishes of the commission are. The first sentence, if you take out interview the patient, is that sentence, are you in agreement with that sentence? Since it says medically necessary? And then just kind of leave it at that?
Yeah, I don't have a problem with it. The English major in me wants to like shorten it down.
Yeah, take out the medically necessary, because it says
Right.
it up.
I mean, if you have uses telemedicine shall collect the relevant medical history and perform an examination as is clinically indicated and just done.
So this is the section
and you
you're
can
going
remove
to,
relevant. You could just say collect history and perform an examination as is clinically indicated.
so this is the section you're going to rework, right, Mike?
Well, that's what I wanted to get clear on.
Okay.
Do I rework this between meetings, or do you want to? I sense that you like the first sentence, but I would love to rewrite it.
Yeah, we can bring this back to the next one because we only have about 33 minutes to get through our 3 comments. So, Christine, if you want to go ahead and move us along.
All righty, will do. We have 3 comments that we received. The first is from Americans for Vision Care Innovation. The panel will begin the discussion. Attendees, if you have a comment, please use the raise your hand function.
So I think I had a conversation earlier with Mike, and I think most of the issues in this particular comment have been dealt with. As you can see, it is rather old now. We're still processing the comments we received prior to our previous workshop.
Are we looking at this something, Amelia?
Oh, hold on. You are now.
Oh, okay, great.
My screen, I have to pause it because if I scroll a lot, it can cause issues for people. So.
Okay.
I think every issue in here was dealt with before this meeting, and then one was dealt with during the meeting.
Oh, because we talked about the practitioner-patient relationship. So I think this one, unless any of you have any questions, I think this one has been resolved. Oh. Okay, it looks like I might have a hand raised. Nick, did you want to speak again?
Yes, I'm not sure if this is the appropriate time, but we are a member of the coalition, and there is an additional comment or request that we would have if it would be appropriate, but it's in a section that has not been discussed yet. It's pretty brief, I think. If now would be the appropriate time.
Sure, okay. If you want to, if it's brief, go ahead.
Yeah, on page 19, 655, the idea that a physician needs to be identified and their licensure status and credentials prior to the provision of care, we believe is not always appropriate when using asynchronous telemedicine technologies. And so, however, we do think that it's important and appropriate. For a service like ours, we would not have that information available to the patient on the front end, but when they get their treatment plan or prescription information, all of that relevant information would be included in that email and on the prescription, and then they would have the ability to follow up with the provider after the fact. So just a comment and I guess a request that prior to language be removed, or if the group would consider removing that. Thank you.
Any comments on that one?
Can you show us where that is?
It should be on the screen.
Is this something we just remove the prior to the provision of care? I mean, the issue is when you can do it, right?
I think that's what he was saying, yes.
And I do agree with asynchronous communication that's not really a valid requirement.
So you're saying strike prior to the provision of care? Dr. Trescott?
Yes, I'm thinking so. I don't know how that reads, but
How is this done in person?
I think there's this, the same issue applies in person. I mean, if you walk into an urgent care clinic, you don't know anything about the provider you're going to see until you actually see the provider. So you can't verify any of this prior to getting the care.
and even after the care, you really don't. A lot of people call our PAs doctor. I mean, in urgent care, it's a common event.
So do you all agree to striking that then?
Yes, with striking it, but I think in some fashion or other, they must be required to provide licensure on request.
I agree.
They have to have some mechanism for saying, yeah, I'm who I say I am.
Yeah.
Yeah, so it's just striking that phrase prior to the provision of care, not the whole thing.
And the gentleman that brought it up, is that Nick? I guess. Does that take care of the concerns from your organization?
Yes, ma'am. It does. That's the only thing that we were saying is if you have to do it before that they get their prescription or their treatment plan, companies that use asynchronous technologies would have no way of doing that because we collect the clinical data and then it goes into the queue for the next physician to look at it. And so we wouldn't be able to do that prior to, but when they get all of the information back from the provider, it would have all of that information in there. We think that that's appropriate. So just removing that, the last part of that sentence would be fine. Thank you.
Perfect.
Thank you.
Perfect.
Then we have one other hand raised. David, if you want to go ahead.
Sure. So if we're discussing 655 right now, I think one of the takeaways that I had in discussing this section with our members is that it's kind of vague about, how you're supposed to be providing this information. And then, the part that says ensure that the patient has the ability to verify the identity, to verify. I guess one question is what does that look like? Ensuring the ability that the patient has, or ensuring that the patient has the ability to do something. Not all patients are able to, do an online search to get that information. They may not think of it during the visit to ask for that information. So I think that could use some clarity on that. And then, let's see, what other feedback did I get on this? Just a lot of questions about when this is supposed to be provided. Is this meant to be done at every visit? Is it meant to be done at the, you do the first visit and then as you build that relationship, you don't have to do it? I mean, what is the intent behind this? I mean, I think it's a good idea to have people identifying themselves and making sure the patient's identified, but I think there needs to be some more parameters around when this is done and how this is done. And, you may want to consider this along with some of the other disclosure ones later on at a future workshop, because I think this gets into some things that could, I mean, depending on how long it takes to do this, you could be eating away into the time for a visit.
So I'm sort of wondering if after ensure the patient has the ability to, if you get rid of the word verify and maybe change it to something to the effect of has access to the license and credentials and identity of all healthcare providers who provide telemedicine. So what you would be saying is that they have access to it because they have access to it in person. If they say, I want to see a copy of your license in my office, I can bring it to them. In fact, it has to be displayed someplace where they can see it.
Yeah, I mean, he has a good point about, I mean, how do you ensure that? So do you provide him a copy of the license? Is that what we're asking?
That certainly wouldn't be, that would not be hard to do by telemedicine.
Right. Because like you said, they may not have access to the internet. They may not be able to do a provider credential search. And so, I mean, is that what we are intending with this section, is that they have a way to see and verify someone's license?
I think that what we're trying to do is to be sure that they can legitimately expect to know who their provider is and what their licensure status is. And I think that if something goes wrong, I think the responsible party needs to be clearly, you need to be able to clearly identify the responsible party.
So maybe,
I can see where that would be difficult for a patient, especially if they're an elderly patient who's having telemedicine services, or for them to be able to verify all of those. We get calls, I get a lot of calls requesting us to verify providers and ask about them prior to getting treatment. So
You could also say on request, provide verification.
but we may have to rework this section as well. I'll work with Mike on how to reword it. So we do have a couple. Go ahead.
Maybe the onus should be on the provider, not the patient. They have more access to that in their offices than a patient does. But we could, but you're right, we could rework that.
Okay, so I think we've dealt with this Americans for Vision Care Innovation, and we're moving on to the next one, correct?
We are, which is from Dr. Barry Edwards.
So I think that we have dealt with some of these things.
We have. We've dealt with all of them, and the ones that we didn't are carried over into his second email. This first one was back in October, based on the prior draft, which was very different. So I think if we focus on the points that he makes in his second email, I think we'll cover it. And if he's present, he can correct us if we're wrong.
I don't see him, so I don't think he is present, but no. So I think the second one, nope.
And
are
Mike,
you just talking about this? Sorry.
I was just going to say, would it be our standard in working on rules like this, wherein we would have a pretty good, what's the phrase, essentially where we would define all of these different terms, right? Because a lot of terms that we'd be using in this document might be somewhat unique. So, I mean, that's, I felt like that was a fair amount of what this person was getting at, of just defining terms appropriately. And then there were a variety of comments on this, like what we were just talking about of defining who is who and how can you really do that and verify it all the time, et cetera, which I think we've talked about a fair amount of it.
Yeah, he first talks about defining telemedicine, which we spent the last couple of workshops going over. He says we shouldn't include, I guess he says we should state that it doesn't include setting appointments, requesting refills, and other purely administrative communication. Since we're defining it so broadly, he thinks that those non-medical activities could fall within the definition of telemedicine, which I don't think the commission wants to regulate.
There are no hands raised.
for the last comment?
I believe so.
He's got it. No, he's got another really good issue.
Okay.
Dr. Edwards talks about the location of the patient in his last paragraph, which is an interesting one, because we say that the location, the practice occurs at the location of the patient, and that's based on an agreement basically among all the states that they're going to regulate, they're going to protect their citizens, and so they want to, if someone's going to treat a patient in their state, they need to be licensed in their state. That's not a Washington law, but that's in your guideline, and that's the general consensus across the country that that's how telemedicine is going to be regulated. It's going to be regulated by the state medical boards and other entities, and it's going to be based on the location of the patient. But Dr. Edwards raises some really good issues about patients moving as they're being treated, and how do you verify where they are? And I don't have a perfect answer for him, but I would say that in medicine, I assume physicians have to rely on patient reports all the time, and patients can be dishonest with you. And a patient, you can talk to a patient, let's say via video chat, and you can say, "Where are you?" And they can say, "I'm in Vancouver, Washington," and they can really be in Portland. I think it comes down to, as it usually does, reasonable prudence by the physician. If a reasonably prudent physician has a reason not to believe the patient, like the patient says, I'm not taking any opioids. If you have reason to believe that patient is lying, then that affects your treatment decision. But if a patient appears honest and says, I am located at my home in Vancouver right now, I don't think anybody would fault you for believing that patient and then treating that patient.
Well, Mike, actually, this has already been addressed. And I think the reason that it's already been addressed is because if somebody who is a patient in Washington is somewhere else, they're in Oregon, it's not our laws that apply to them, it's Oregon laws, and we can't alter that one way or the other. That's a national thing. If the doctor is in Oregon and the patient is on their way over to Washington, we've already addressed that that's okay. So yeah, I don't think I would do anything different with this, because any Washington physician treating a patient who tells them they're in Washington and they're outside of the state, if they're outside of the state, that's not our business. And there's nothing we can do about it, even if we wanted it to be.
Okay, he raises another interesting issue that I don't have any answer for, and that is when you're dealing with multiple patients at the same time and they're all in different states, which I guess can happen in psychiatry, and he's a psychiatrist. So
it could happen in diabetes care, it could happen in a variety of different things. But again, as it relates to, we don't have authority over what happens in other states.
I'm not saying the rule should address this. I'm saying I just don't have a good answer. Maybe this is something that we should definitely not address.
Yeah, so regarding the issue he raises of family psychotherapy, family psychotherapy is always provided to treat a patient. That's a modality of treatment. So there's always an identified patient, and the issue is where the identified patient is. And now that's not something that I would advocate putting in rule at all. That's just to address that. That's, it's up to the treating provider to figure that out. So if members in Washington, but the identified patients in Oregon, then it goes back to what Alden said, is the rules in Oregon apply, not the rules in Washington.
I have a question. Do we anywhere in the rules bring in Canada? And this came up on the boat thing. I mean, when people are on their boats, they're very easily in Canadian waters here and not in Washington waters.
Well, again,
Does the language include Canadian anywhere?
No.
If the patient is in Canada, we can't do any, I don't care where the patient is. Because it actually has, we can't govern anything that has anything to do with where the patient is. We can only govern where the doctor is.
Well, sometimes doctors in Canada too. Sometimes the doctor's on a boat in Canada too.
If the patient on the boat has drifted into British Columbia waters, then the jurisdiction is British Columbia, not ours.
Okay.
So, Mike, have we taken care of all of these then? With Dr. Edwards?
Yeah, under standard of care, the first sentence about, he says standard of care includes the use of the present medium to determine the best setting. I think he's referring to section 658, if I understand his point right, that the particular technology the practitioner is using will help determine whether the standard of care is met, whether the treatment is appropriate. So if you look at 658, I have something for your consideration. Appropriateness of telemedicine.
Mm-hmm.
And this may be a section that, given your thoughts on other sections, you may want to scrap entirely.
I will say I find this somewhat problematic. And there's certainly not insignificant number of circumstances where it's initially the patient's decision to seek net telemedicine, not the physician's.
I also think that in the practice of regular medicine, got somebody on the phone and say, or in the office, and you say, I think you need to go to the emergency room.
Yeah.
I think this is one of those other issues that I'm not sure needs to be addressed at all. Basically, it's still back to you got to provide good care.
And
So
I think, go ahead, please.
Do we want to delete that whole section?
I'm leaning in that direction. I mean, I think the appropriateness of telemedicine is a moving target. It's not static.
Well, and I think that there's currently in practice where there's probably nurse lines where a patient might call in and talk to an advising nurse and say, hey, I need to bring my kid in for X. And the nurse will ask a set of standard questions and say, oh, I think that can be addressed by Dr. So-and-so who's available by telemedicine, right? And they would be in violation of this rule to an extent. I mean, because it says only the treating physician's empowered to make the decision to use telemedicine. I mean, of course, the physician then sees the patient and could say, oh gosh, I need you to come into the office, but they're already doing telemedicine by the time they've done that.
Yeah, I think you're right, April.
So remove it. Oh, sorry. Go ahead, Mike.
This is just another one of those that says use good judgment.
Exactly.
Unnecessary.
So that's your vote. Strike it, correct?
Yep.
Yeah.
Dr. Howe would be so proud of you. So I think we can move to the last comment then.
Yes, from Eric Fader.
Yeah, this is an email that I got last October, and this is just about the issue about how to establish the physician-patient relationship. So I believe we've addressed this issue.
Any other comments about this comment?
First of all, it's interesting that someone in New York wants to know our rules.
No other comments or hands or chat, Amelia,
Oh,
looks like.
there is one hand. Oh,
Oh,
two
okay.
hands. Hold on just a second. Jeb, if you want to go ahead.
Hey, thank you. No comment on this email specifically, but was wondering if I could maybe share some general thoughts on the rulemaking now that we're nearing the hour mark.
I do have one other hand raised, which might be relevant to this comment. So if you can just wait a moment and I will unmute you again when they are through.
Great, thank you.
So Tammy Brooks, if you would like to go ahead. Maybe, maybe not. You want to go ahead, Jeb?
Yeah, thanks, Amelia, and good afternoon again, everyone. Jeb Shepard from the Washington State Medical Association. I just want to start by thanking the Commission for hitting pause on this for the last few months. You know, with everything that's been taking place, it's been difficult for us to meaningfully engage on this rulemaking. So thank you for that. Now that we've had time to review and talk through some of the provisions with clinicians and colleagues, we have some concerns with the approach to the rulemaking that I think were raised sort of organically throughout your conversation today, and that's generally the breadth, scope, and prescriptiveness of the rule. So if we're looking at this broadly, placing this many prescriptive requirements around telemedicine, which could subject physicians to professional discipline, will place barriers to patients seeking to access care through this modality. We think that much of the rule could be summarized by follow existing state or federal law or regulation, and we just don't think that's good or appropriate for our rulemaking. So here's our ask would be to not, entirely blow it up and start over, but sort of narrow the scope of the rule to focus in on some of the key elements. So, for example, a rule could discuss licensure, standard of care, and appropriateness of telemedicine, and leave it there. Many of the other provisions, as I noted, are either duplicative of existing requirements, and state and federal law would limit access to telemedicine or are too prescriptive to apply in the limited context of a 10 to 15 minute patient encounter. So focused regulations could be supplemented or updated by with the guidelines that were referenced earlier. So those already exist. So those could be, we could take a look at those, or we could start from scratch and come up with some guidelines to supplement the regulatory stuff. And I believe that's the approach that the Nursing Commission has taken, for what that's worth. And then the Medical Commission always has the authority to revisit these rules as demonstrable needs arise based on patient complaints or input from clinicians in the state. So this would build sort of a regulatory floor that you could build on as the modality evolves. So just wanted to urge the Medical Commission to consider that approach going forward. And Thank you very much.
Thank you, Jeb. And then we do have David Streeter has his hand up again. So go ahead, David.
Hi, I just want to follow Jeb and say thank you to the commission for pausing on this rulemaking during legislative session and over the last couple of months. It's really been helpful to have some extra time to process this and socialize the proposal with our members. I just want to echo Jeb's sentiment about paring down the rules and thinking about sort of the things that must be in rules and looking at other things that could be done, guidance documents. We got some good feedback from our members about the approach the Nursing Commission took with their statements that they put out. And you know, I think for some of these issues on here, I think Deb has a really good point that some of those things could be addressed through guidance documents rather than rules. So appreciate the discussion today, and you know, please let us know if WSHA can be a resource to you as you continue developing these rules.
Thank you, David. There are no other hands raised.
Are there any questions from the attendees that haven't been answered?
Let me make sure. There was a question that asked, would organizations such as ZocDoc apply to this situation?
I'm sorry, could you say that again?
It said, would organizations such as ZocDoc apply to this situation? I'm not sure what ZocDoc is, maybe others are familiar.
Does anyone know what ZocDoc is?
I can look it up.
I think
Let's look. It's probably a telemedicine company. That's what it looks like.
It actually doesn't look like that. Just looks like a search for doctors platform.
So I don't think, I mean, if they're not doing telemedicine, then this it's just
well,
a
we
search
also don't have the
platform.
ability to we would not have the ability to regulate those folks.
Okay.
Okay.
It looks like all the questions.
Thanks. Thank you for your participation. Amelia is going to discuss next steps now.
All right. Get this started. Sorry. So we've revised our rule development timeline. And as you can see here, we will not present the draft language until probably the January 2022 meeting. And then from there, we'll move through the process as we can based on what that decision is at the January meeting next year. And then our next steps will be that we will hold a workshop in either June or July, and then we will hold another one in likely August or September. And hopefully at that last workshop in August or September is where we will finalize these draft rules. We will try to get all the comments taken care of at the one that will be held in June or July. And then if you need to contact, then there's my contact information.
Is there anyone else that wishes to comment?
There are no other hands raised.
All right, then I will close the workshop. Thank you all.
Bye, everybody.
I wish
Hi,
I could wave, but I'm waving. Thanks.